Okay.
All right. Welcome to Journal Club, also known as Critical Appraisal Seminars and Anesthesiology Research. Yeah, it's a fancy title I took off of one of the graduate school classes, except it's in anesthesia, so it's great. So here's our learning objectives today. Hopefully you guys all had a chance to take a look at the article. And I think we sent out assignments this time, so you each have your own section to sort of go through. The overall goal, though, is we want to look at a clinical trial study design, look at sort of what goes into that, how to evaluate it, sort of look for indicators of study rigor, things you want to look for when you try and decide whether the results of a clinical trial are important for your particular patient that you're taking care of, or whether you should alter your practice within that. And one of these big questions you need to think about is generalizability. And we'll talk about sort of what that means and sort of what are the different pieces that go into it. And then for this particular manuscript, this is a secondary outcome variable that they looked at. They looked at a bunch of secondary outcomes. It was sort of predetermined what they were going to do, but it's a long-term follow-up of a clinical trial from a couple years ago. So we'll just start with the introduction. So this is the manuscript you guys all read. One of the important things with an introduction is to understand sort of what the background you need to know to understand the context where the work has been done, right? So there's a few pieces of information that you probably need to understand what's going on. It's also important to know what other people have done and tried prior to this particular work, sort of how these new results fit into the sort of bigger picture of what's going on. So do we have introduction people here? Yourself? Anyone else?
I think you're the only one.
You're the only one? Okay. So, all right. So we got this title, Postoperative Pain and Analgesic Requirements First Year of Intraoperative Methadone, Complex Spine and Cardiac Surgery. So what do we need to know to place this work in context? What's important? What should the introduction tell us?
I think sometimes, too, it's also important is like why we should care. And I mean, this one doesn't dive too much into it, but I think the first paragraph does is like mainly pointing out acute and chronic pain, and I think it doesn't say it, but we all know that chronic pain is a major issue, and we're trying to evaluate things that affect the perioperative pain control, and it kind of talks a little bit about what goes into that. But in terms of what's actually been done, it mentions things that they've tried like gabapentin, Lyrica, ketamine, lidocaine, clonidine. But the main thing that they've been trying to see for this study is whether methadone, potential NMDA antagonist, is beneficial, and it tells about previous clinical study that used 20 milligrams of methadone, and this one says at induction, so not necessarily before, but actually during induction. And then it mentions why that's also important, like saying that the NMDA receptor is kind of thought to be play a part in terms of hyperalgesia, and then also opioid tolerance as well too, which I think is pretty important. And then the thing it kind of mentions is I think it followed 2 clinical trials comparing the pain scores of the analgesic requirements, where it was basically compared to people who received IV methadone and then those who had received basically IV opioids. And I think that one was primarily hydromorphone, the ones that they kind of compared it to. So it's also nice to know what that study used,
Right.
So that way you can know what they're kind of assessing.
Yeah, and this is the same group of people. So they planned out this study. They were going to look at sort of the immediate effects because it makes sense that maybe on the day of surgery your pain might be better controlled, maybe you have lower opioid requirements. But they also wanted to do sort of long-term follow-up to see if it had any impact after patients left the hospital. This is actually, I think, a really important point that people are starting to look to, not only in the field of post-op pain management, but also looking at these sort of second effects of some of our anesthetic choices. It's a whole idea that what we do on the day of surgery may have longer ramifications, either positive or negative. So in this instance, they're looking at what sort of analgesic regimen we do and will it affect patients a year out, 3 months out, just during their hospital stay, that sort of thing. And another area where people are looking at this pretty actively is TIVA for cancer recurrence, right? Because you make a pretty good argument that TIVA versus volatiles are both very good for their primary purpose, which is maintaining anesthesia, analgesia, all those sort of, not necessarily analgesia, but all the goals of providing anesthesia. They're able to do their primary purpose very well, but it's starting to look at what else can we do with our anesthetic choices. So it fits into this like overall paradigm of what else can we do with our tools. So that's sort of how that fits in. And they're a little different because it's one group of complex spine patients and then cardiac surgery. And so pain requirements might be different in that scenario. And they're telling you up front that they're going to look at these together because they're both, the intervention's the same, the circumstances around it are different, right? Anything else that we might need to know to understand the context of this, or?
It kind of points towards their discussion, but having some data to support that methadone may have an effect long term, like you're saying. And they mentioned some stuff in the discussion, but I'm not sure if that's warranted in the introduction at all.
It might just be put in the context of the specific results. Yeah.
And just for the people that have the intro, I haven't heard it yet, which is one of the things that to me, it's the only reason to read the intro. Is there a hypothesis statement? Because the hypothesis statement is going to set up the methods, it's going to set up the results and set up the discussion. So was there a hypothesis statement? And what exactly was it?
They even said we hypothesized that patients administered methadone would have fewer episodes of pain per week.
Fewer episodes of pain per week.
Post-operative here.
Okay.
Okay, so we'll come back to that. That's an important point for methods because how you set up your hypothesis, what you're actually testing, determines whether you know that you succeeded or not. So if you need a testable question, I mean, you could sort of a bad hypothesis would be really broad. Like
Right.
we think methadone will help people get better outpatient appointments. Like there's no connection to that. Like, that has nothing to do with it, right? But if you have a very specific targeted hypothesis, you can test it and then you know whether your study was successful or not based on criteria that you set before you even started. So that's why it's really important.
Yeah, and it's a shortcut for reading articles because if you go to that last paragraph of the intro and it's either a bad hypothesis or one you're not interested in, you can stop reading.
Yeah, there's a few exit points, right, along there. That's a good.
So you learn a little bit about the background and you go, oh shit. This is
I'm out. Yeah.
I'm out. But this is not bad.
No, this is a good.
This is
Yeah,
a good
I'm curious.
hypothesis. But yeah, it does set up the what they're going to do.
Okay.
They're going to look at episodes of pain.
Right. And so that gets us to our.
Kind of unique. I haven't seen that before.
Yeah, what does it even mean?
What does
Maybe the
that
methods people can talk about it because that's. All right, so this is anytime you have a clinical trial. We've sort of gone over this before for people who have been in this seminar previously. This is sort of a map of what you need to look for. It's sort of the moving parts of what they did. So you start at the top. You have a certain number of patients that actually they approached and then randomized. So you know your starting number, how they split them up, and then what they did. So this is a little complicated because they have different follow-ups, and you can't always find people after they have surgery. Or they don't want to talk to you, they change their phone, like anything can happen. So part of keeping your clinical trials honest is having really good accounting. That everyone who you talked to and enrolled is accounted for. Even if they said they're dead, we can't find them, they moved, whatever, they need to be in there because the flip side of all these sort of things is that all of these have been abused in the past, right? So like before you had clinical trial reporting or these very strict guidelines on how to do clinical trials, all the grumpy people, maybe they didn't call you back. And those are the ones who didn't do well in your trial. So your drug looks amazing, but you threw out like 1,500 people who said they quit because of side effects. So to avoid getting away from that, or to get away from that pitfall, it's about accounting everyone who got randomized. Where did they go? What happened? Even if you lost track of them. Because then that can call into question the validity of your study, right? So if you're like, well, we lost half the people, we don't know why. Suddenly you don't trust it as much because that's either most likely not a random event, which is really important because your whole idea is that you can control this. Doesn't matter, you show up on surgery, your day of surgery, and you're randomized. That's the only thing that's supposed to be different about you. So that's what they're looking at. So that's part of the methods. Who are the method group people? Yeah, do you want to take us through what they did, what we need to know to make sense of this?
Yeah.
with those two different studies or procedures they looked at, which was the spine and the cardiac. And so with the spine, obviously this is up here, they either got hydromorphone or methadone, but they got them at different times too, which I think is important. So the methadone got it at induction, hydromorphone at the surgical closure. And then they followed them up, analyzed them, obviously, to post-op day 3, and then they sent out surveys, basically 1 month, 3 months, 6 months, a year, and then called to encourage them to completely fill it out and mail it back. And so they had a self-addressed envelope and stuff. But if you can see with the spine one that's up here, I mean, down at the bottom, patients with a complete set of data for all follow-ups was only 28% or 32%. So people either didn't follow up or at some point in the procedure weren't completely on it, you know? Mm-hmm. And then at a year follow-up, you can see a fairly significant difference of like 49% versus 65% for one group versus the other. So like we're talking about, maybe that's significant, maybe it's not, but it's a decent amount. Mm-hmm. Either way.
Yeah. And there's another important part. You want to look at how you get into the trial, because this gets to this the idea of generalizability. So there's sort of two ways to go about if you're starting a clinical trial. You can enroll everyone, or as broadly as you can, but then you are going to have issues with people being more different from each other. So you don't really stack the deck in your favor. So it either has to be a really great intervention that works for everybody, or you need to enroll a lot of people. Enrolling a lot of people is very expensive, so that's not usually the way they go. So the other way is you can enrich. So in enriching, you can say, all right, well, we want to know if it's people who have no pain starting out, like low baseline pain or whatever. You can enrich for people to just look at the effect of methadone. The other way they could have done this was you take the worst of the worst, the people who have 10 out of 10 pain when they show up, and then now you're enriching for chronic pain. But those are two very different questions, right? One is like, what do the surgeries do to you and can methadone help? The other is if you're already in severe chronic pain, what does it do to your acute on chronic pain? So looking at the inclusion and exclusion criteria really helps define what the population is. So back to the easy exit points. If you get to the hypothesis, it's like, okay, methadone does something for acute and chronic pain. You get to the methods and you're like, in preterm infants for whatever, and you don't take care of any of these patients, maybe you're done. You find a different paper. That's the other part. So did they say what their inclusion and exclusion was for this? Or sometimes they just cite the original paper without going into it?
Yeah, I think in this one they just said it's a follow-up of 2 randomized double-blinded investigations.
Yeah.
So they didn't give the criteria for the follow-up,
right,
or for the original studies.
Yeah, so if I remember those studies, I think they were not terribly restrictive. They went with a more broad approach. People just, I think the main inclusion and exclusion was like able to provide informed consent, adult, elective procedure, pretty reasonable, generalizable components. I think too, since it was only 120 patients, I think they had a good idea that there'd be a large effect size, such that the differences between people would not be as big as the differences due to the intervention. Let's see, what else do we need to know to make sense of this? Stats, probably, right?
Well, one other thing I just wanted, you had said that one got it at induction and one got it at the end. And you said that made a difference in your mind.
In my mind, unless the people, like in the post-operative period, were not the ones that took care of them intra-op, like as the in-room provider, you would know if you're giving it at different times. So perhaps that's not blinding the intra-operative provider, but they're also not really looking at the right post-op period. So maybe that doesn't change things all that much.
Yeah, that was good. Yeah, my way of looking at it, and this comes up a lot when you're doing, not this particular thing. And I think they were randomized and blinded. I don't think the in-room provider knew. I think they had syringes that were marked.
Or just, blank study drug that you just run in on a 50 ml bag.
In the end, but one of the questions, because you could argue that, well, maybe the ones that got hydromorphone at the end experienced more pain intra-op, and that maybe accounted for the difference. And if they'd have gotten it up front, So this is a problem when you're doing clinical trials. Do you want an answer to the clinical question? Because everybody gives hydromorphone at the end of the case. Everybody gives methadone at the beginning. You're going to compare your clinical things, or do you want to do this, address the science? Or, do you want to address the clinical question, or do you want? And that's always a tricky thing to do. This group, and I was wondering when I was going to get to talk about this group. This is anybody from Chicago or know about this group? So this is a private hospital. This is Evanston Hospital. They've always had an academic affiliation. They've always had 2 or 3 people in the department. You're from there?
No, we were talking about this group before.
Yeah, they always had 2 or 3 people, and now it's Glenn Murphy is the main one, who does really relevant, good clinical studies, and that kind of keeps them as an academic, and so they get medical students and residents and all that sort of thing. And Mike Avram, who was the second author, has worked with them for a long time. He's actually at Northwestern now. Northwestern and Evanston split about a decade ago. So their appointments now are with the University of Chicago. Again, it's still a private hospital. They don't get any money from anybody else but themselves. And they fund, so their questions are going to be more clinical. Mm-hmm. Mike Avram is the assistant editor-in-chief of the journal. Mm-hmm. So, the study may have some problems, but as we're going to get into the stats, I think you'll see it's well designed and well conceived on that front. And simple, because I know Mike, he doesn't like complex stats.
Yeah, I would agree with that too, because there's a lot of mistakes you can make with that. You start with the simplest model that you can, just try and power it well, especially for clinical trials where you have a lot of control. You don't have to make as many compromises because you can really get at that cause, because you're trying to just change the intervention group alone, and that makes a pretty strong argument. So before we get into that, was there, with the methods part, were there any fancy statistics, or what did they do? I think it was pretty typical.
They had a lot of different types of data, they had the ordinal data and a couple other different tests. They had to use different types of testing. Mm-hmm. So they used the Manway EU test, and they had percentages, which is the chi-square testing. And they also used Fisher exact probability testing.
Yep.
So there were they had to use a bunch of different tests because they had different types of, on their surveys, they couldn't fit all in one type of category where they could just compare all the same test.
Right. Those are all pretty bread and butter comparisons for those type of data. Those would be sort of your first choice on those without having to get into more complicated models with that. So
could you talk a little more about their main ordinal data? And the reason is this is kind of funny, I had somebody come up to me saying, I saw your journal club thing, I think it's garbage. Do you see how many zeros there were on the table and how many were P less thans? And so I was like, 0. They went straight to the table.
Right. They thought 0
that wasn't
pain or something.
Or 0 incidents.
Yeah.
So what did those?
Yeah.
What was the ordinal scale? This was a misread table.
I guess the main was just frequency.
Right.
That's what they're looking at. So 0 was none, 1 less than twice per week, a 2 designated twice per week or more, and 3 was daily. So that was kind of their main.
Right.
For the
and what do you think of that scale? I think it's a totally made up scale.
yeah, it sounds kind of bogus.
I don't think they cited anybody.
No.
I mean, it's not a bad scale.
No, I mean, it's pretty clinical. I think it probably tracks with patient's experience,
Yeah.
right? I don't know if it's validated. That's sort of the other
Validate
point.
it maybe.
Yeah.
And they evenly distributed.
Yeah.
They brought that up in the discussion too.
Yeah.
They had not used a validated scale.
Mhm.
They should have.
Yeah.
But they said a priori.
Oh yeah, so they said so when you call your shots, you get some credibility for that, right? Like we made this up, but if it doesn't work, we'll tell you it didn't work. I mean that's not bad, right? I mean, it's sort of it seems like a pretty clinical test because if someone's having a problem every day, that's different than someone not having any problems at all. We can all agree there. And this is usually how these scales work. It's like the extremes are not really in contention at all. It's in this sort of gray zone in the middle. So if you divide out into like, oh, everything went great, there's no problems, to my life is miserable now that I had this surgery, that's fine. You don't need a fancy validated scale. I think patients would care about that, providers would care about that, that's fine. But I think when you get into the shades of gray is when you can start having arguments over validated scale or not. Because you want to look at your tools like that and see what they're good at and sort of where they'll break and sort of fail. And I think it would be in that middle. Is 2 a week different from, what was the other middle ones that they sort of?
It was none, less than twice per week, 2 or more, and then daily. So there might be like a 2 times a week versus maybe 5 times a week, but that would be the same number.
Okay.
You know?
But less than 2, isn't that 1? Less than 2, but more than 0?
Yeah, so
Yes.
basically it's none,
1.
1 or 2, and then
Okay.
2 to 6
So,
daily.
so
You
less than or equal
So
to.
let's get back to the hypothesis. Reread the
Yeah.
hypothesis. And this is how they're measuring
Yeah,
it.
we hypothesized that patients administered methadone would have fewer episodes of pain per week.
Right, on this ordinance,
Right.
yeah. So anyway.
On the
that's-
order, so they didn't take it continuous.
No.
Which is important because, it's different if you can tell the difference between 1, 2, 3, 4, 5, that's a whole different metric compared to which category are you in. So,
Yeah, I don't know if it makes that big of a difference,
Maybe
but it's
not.
interesting that
Yeah.
that's, those are the kinds of things you're really doing the stats and making statements that you have to kind of grapple with in your mind, is how far you can take this.
Yeah, I feel like if their data wouldn't have panned out the way it did, then there would be a big problem with their scaling. If, like you said, there was a lot of hitting the mark in that gray area, well, now their scale can't differentiate, so now it's kind of useless.
right, or even if it could, would you believe what it was telling you?
Right.
That's the other part. That's what the
Yeah.
validation comes in.
Yeah, and I think in the cardiac group, they ran into some problems.
I also wonder how well the survey respondents understood the definition of an instance of pain and whether they all scored it the same way.
And that's what the validation process will teach you about your metric, right? But we don't have any of that. So let's see, how much did that matter? Who had results? Do you have results groups?
Anyone?
Everyone else's discussion?
Doesn't look like anybody on results is here.
Okay, great. So, all right. So, in a lot of ways, that's the most straightforward section because they just tell you what they saw. So, method sets up how we're going to do that, questions we're going to ask, how we're going to measure it. We're all going to agree that usually p less than 0.05. So you sort of set the rules of the game, and then the results just tell you what happened within that.
Yeah, getting back to a couple of things they did, they went to 01 because they knew they were sketch. Now, they mentioned that they had, not evenly distributed. This is an unvalidated thing. We're gonna not declare it unless it's 01 or less.
Mm-hmm.
So they didn't go 05. So I think they tried to compensate a little bit.
Right. So do you guys understand or have a rough idea of sort of what that, so the p-value discussion, there's a movement to say we shouldn't be doing p-values at all. But that's a little extreme.
What do we do in the place of p-values?
Yeah.
Good question. So what is a p-value? What is it trying to tell you?
So it basically is telling you the confidence that you can say that this is a valid result. So a p-value of 0.05 is like you're saying that it's 95% confident that this is going to be a true result. There's still 5% left up to random error.
Mm-hmm.
So 0.01 would be 1% random error and 99% confidence.
Yeah, and so it's on this, philosophically, it gets back to the frequentist argument, and that's saying that this is a very uncommon result. If we did this study however many times, 1 out of 20, we'd get a result that is this extreme or more extreme. So if you move that benchmark further, then you say 1 in 100. So it's a better argument. This is even less likely. There's another school of thought, like the Bayesian thing, which takes in the probability of something else happening. And there's some places where the frequentist argument breaks down because things that happen 1 out of 100 times happen still pretty regularly. So depending on what your question is or how you design it, that could be a good argument or a mediocre argument with that. And some of that too gets a little strange when you look at multiple tests, right? So just if you do 20 tests, you get 1 free, right? Like 0.05. If you do 100, you'll get 1 of those. So then by correcting for that, there's different ways to do it, but there are some issues with sort of the frequentist argument.
Yeah, and you've seen there's a movement to make it hard, the statistical test harder, because a lot of clinical research and even bench research is not reproducible.
Yeah.
So they get a statistically significant finding, they move on, and then somebody else goes to repeat it, and they can't.
Right.
They don't see it.
And that's part of it. And there's a lot of reasons for that. I think we'll spend one of the sessions on some of these issues, but part of that is from the culture of bench research. So there's this imperative to use as few animals as possible. So typically experiments are done with maybe N of 8 in each group, something like that. So you need a massive effect size. But the issue with, let's say you just barely make it over that 0.05 threshold, if you redid the experiment, you have a 50-50 chance of getting the same result. Just because it'll bounce around that 0.05, which again gets to this reproducibility crisis. So if you're not going to get a good answer, why bother at all, right? So there's a lot of there are a lot of issues with that. So that gets back to the generalizability part with the results. If it's a very clinical scenario that matches sort of what we do anyways, with broad inclusion criteria, it's more likely that you would probably see this in your own population if you repeated that. And then using that higher threshold of 0.01 makes it a more compelling argument. But it's just an argument, because winning the lottery is like a 1 in 100 million, but someone wins that like every week or so. So that's part of the issue with that. So what do we got? We've got the table 1. So it's usually the demographics telling us about what the different groups are, and the goal with randomization is to have balanced groups. So this is one of those scenarios where you don't want statistical significantly different results. Oh yeah, we don't have any results, people. So that's usually how table 1 is set up. You look for how balanced are the two groups. Can you actually compare them?
The results group is a great example because I randomly picked people and it was unbalanced. There's nobody.
There's a lot of confounders there, though.
Yeah, I know. Right?
Right. Yeah, exactly.
Randomization didn't work.
It didn't work. So you need a bigger group.
So you still got to
right?
look at it, even though you did it randomly. You got to look.
Yeah, and we did get a difference that fell out, right? So
Yeah,
they're
with age.
different age. So it happens. But then you get a variant result like that. You got to say, would age matter for what we care about with this study? You can make an argument for or against, but that's probably one of the weaknesses. That randomization wasn't great. Maybe they need a bigger trial, do it again, something like that. But I don't know that it fully calls into question all the results. Okay, figure 2. What is going on here? You get a lot of overlapping box plots.
There was less post-surgical pain in the methadone group. Pretty much everywhere, but significant. Like the less than 0.01 significant level of significance in the 3-month group.
Right. So black diamonds are medians, right? Because the bar graphs look terrible.
Well,
Right.
This is the ordinal scale.
Yeah.
And these are
So
quartiles, not standard
I mean,
deviations.
honestly, they could. I'm not sure why they did.
I don't know
box
why they
plot.
chose this.
It's ugly.
This
That all
way,
looks
yeah.
the same.
It's ugly.
Yeah.
Right, because usually with these box plots, you're looking for non-overlapping, those error bars that they actually look different. You got medians that are different, but then also, you don't have these overlapping confidence things. None of those confidence intervals are even on the graph. And the only thing that's we're asked to believe is different is the black diamond, the medians, and that's sort of what's driving the results there. And it does look like the methadone group, the 3 months, 6 months, 12 months, their median value is 0, right? That's sort of the headline for this. Actually, the rest, I don't know that it's adding anything except that they picked a wonky
What happened
measure.
to the shading in column 1?
Yeah, good question.
All the results in the first and third quartiles were on the 3.
Yeah. There's just no variation.
Do you think so? I
Or
don't
they
know.
just
And that was
missed
the
it.
only thing I could come up with. Like, there was not a single person in a different
I guess so. I don't know.
area.
Anyways,
the
this-
whiskers demonstrate that there were people
Yeah.
Yeah,
in all of the
for
other
all of them.
responses. It's just most of them are.
All right, so I'd say the takeaway from this is the medians are different in the methadone group, which, that's reasonable. Those are significant. And, I'd believe it. So we got a big table. What's going on here?
And just to point out, I expected when I saw it, when I read it, that they were going to throw them all in together, but they analyzed each group separately. They didn't talk. So the first one was, they're enough different that they did them differently. I thought that was interesting.
Mm-hmm. Yep, so they break it out by time point, right? It's mostly what this is.
This is spinal surgery.
Okay, so we got spine, differences at each on their weird scale. Okay. Medications required. So a lot of these trials, even their own trials for the first ones, they do morphine equivalents while in hospital as sort of an objective measure. I don't think that would work in this instance because presumably everyone should be off their perioperative opioids shortly after surgery. I don't know how much of a supply we're sending them home with now, whether it's 7 days or, the laws have been changing. But typically that's sort of the objective measure of pain, sort of what you're taking to keep it under control, which has its own issues. But mostly it's the pain score is next best. So we got back pain and leg pain at rest, coughing, movement. This is still the spine surgery issue. So I wonder if that's sort of in their presenting criteria, like why would pain with coughing be a metric? Maybe it's something patients complain about afterwards. Are you guys familiar with this metric? Or
I see that with
Yeah.
front of me.
Just to break out so it isn't just at rest.
okay, so they do something and then
Yeah, so there's with coughing and with movement.
mm-hmm.
Um,
All right.
I think people, they didn't have sneezing. But no, just kidding.
It's a little ridiculous, right? Yeah. Yeah, so sometimes to get at this, they'll do there's a few validated indices of quality of life where you say, how has your quality of life changed? Can you do your normal activities? Or, there's that whole hierarchy, can you work? Can you do your hobbies? Can you do whatever? And there's a few of these other validated questionnaires that try and get at this a little more objectively, or at least that's what those validated questionnaires do.
Well, that was
I
on
forget
the
the name.
previous table.
They had it?
I don't know if it was truly a validated one, but they did.
Okay.
One of the big problems with using metrics like a score, like we were talking about, is that it doesn't get to the true outcome.
Mm-hmm.
Are you back, basically?
Yeah.
So they had interference with sleep and interference with daily activity as getting close to that kind of thing, but it really happened.
Yeah, some of these are subjective, and it's hard to capture that without going into qualitative style research, which is its own branch of research, but then it turns more into like anthropology and like a book report. There are ways to pull out meaningful information out of that, but it's a lot of work. It's very labor intensive. Where you go and you like interview them for an hour and then you pull out themes and and even then that's difficult to quantify. So this is sort of in between that, where you have some sort of agreed upon objective measure, but it's not all the way like a Von Frey filament or something looking at heat tolerance or some other thing that you can directly measure. So it's sort of in between that qualitative and quantitative measure. So I'd imagine, okay, so now they get in, this is the cardiac surgery, second one. So they basically repeat it for the second study they did. So it looks like the follow-up's a little better in this group, or at least equally bad in both. And then same sort of thing. So yeah, okay, so they use the same metrics again for this group. Okay. Go backwards. Just a second. Sorry. Okay.
So no differences between the groups and the cardiac patients.
Right.
Just as an aside, we going to do methadone for cardiac patients anytime soon?
I do sometimes.
Really?
Yeah.
Ooh.
Yeah, you can. So these studies have been out for a while. They've shown that it's safe and effective. The main issue I've had is that it sends some of the post-operative nursing care, it sends a wrong signal or some ICU management issues where they're not comfortable or familiar with it, even though it doesn't change their post-operative management. They seem to take it as an indication that the patient is addicted to opioids or something else. They have gotten some concerned calls from post-op care. That's really the only reason not to do it in my mind. If you're going to use long-acting opioids, it's been shown to be safe and effective.
Yeah, and I was thinking about that too, because one of the issues with you, just as you said, is downstream effects with our surgical colleagues and our nurses, and both in PACU and on the floor. Are they going to be familiar with what to do? But if you look at their original studies, their rescue pain meds looked like our rescue pain meds that we ordered.
Mm-hmm.
So
Yeah,
it
it's
should
all
be
the
the same
same.
care as long as you're titrating the pain. It shouldn't be a big deal.
Yeah,
It's steady. It's not going to be fluctuating.
Exactly. And the barriers are cultural.
Yeah.
So it just depends on how much I think the patient would benefit versus how many phone calls I want to field afterwards.
So we had to go through this when we started with ketamine.
Yeah. Oh, really? Yeah, same sort of thing.
Ketamine? I gave this patient ketamine.
Why would you do that? Yeah.
What are you doing?
Right. Yeah, but it is very effective. I think too, looking at some of the cardiac surgery outcomes, I think potentially what happens is usually after a couple days, their pain is actually not as bad as like a thoracotomy patient. It may have to do with denervating the sternum potentially, or they really don't. I think the chest tubes that they have really block out their perception of some of this other pain that they're experiencing. So I don't think it's a major issue for cardiac surgery patients as is with the current regimen. That's probably why they saw less of a difference. While spine surgery is a pretty prolonged recovery. Okay, so here's the cardiac surgery one. So again, we're looking at the medians being different, but even by 3 months in the fentanyl alone group, which would be your standard of care, they already have pretty infrequent pain with that. So there's probably less of a problem to fix in this population.
But even at 1 month, it was better.
Yeah, that's true.
And it was better on day 3, first 3 days.
Mhm.
So, I mean, this isn't a bad thing to do.
No, very reasonable. So it'd probably just take re-educating our colleagues with some of that to start implementing them. But that's this is another good point. You have a whole spectrum of data and results to inform clinical care, and it goes all the way from very controlled lab animal experiments all the way up through clinical research. But there's another side to it, and I think that's considered like the post-translational. So you've got the implementation side of it. So even though you can have clinical studies, or even multiple, if you had thousands of patients, the people are still uncomfortable using methadone. Despite having all that evidence, there's an implementation problem actually getting it to patients. So that's a whole other discipline in research. And that's part of why it takes so long for things to get from the lab into the clinic and then on actually at a population level where this is what we do normally. So that's sort of a different challenge, and there are people working in that area, but it's an implementation problem. It's not that the drug's expensive, it's dirt cheap. I guess it was on shortage for a little while, but they're making it again. So really those barriers aren't scientific because we know that it works. It's that you have to deal with all the slow-moving infrastructure of hospital systems. There are ways to do that, but it's a separate type of thing. That's the difference between efficacy and then effectiveness. So they define those words differently. Okay, another giant table. Doesn't add a whole lot to this kind of.
But it was interesting. It gets to the question that somebody brought up to me is, what kind of study has this many zeros?
Oh, yeah, right.
And they just looked at that and just said,
What are we even doing? I'm out. Yeah.
I'm out. So at least you all know what those zeros mean.
Yeah.
So.
Okay, and then this is the sort of with activity. Again. Yeah.
It's a lot of zeros.
Doesn't
Zero,
add a
zero.
whole lot. Yep.
Would
0
have
to
made
2.
a really easier table. Just say it's all zeros.
It's all.
guys.
Yeah, for sure.
Filling up a page.
All right, so what do you guys think? Any reason we shouldn't be using methadone for spine cardiac surgery? Why would you do it? Why wouldn't you do it?
I think in spine surgery, the question is there a downside to it? Possibly there's an upside. This study seems to suggest that. Is there a downside to using the methadone? I don't see one right off the bat, so why not try it out and see?
There weren't safety issues. You could say the prolonged QT was one of the concerns, so they put in an EKG for these trials. But in sort of the epidemiological studies looking at that prolonged QT, mostly what methadone does in those rare instances where it does predispose to torsade is it unmasks familial channelopathy. So it's quite rare. You don't, at least for a single intraoperative dose, you don't run into that problem very often because that'd be it's not a very common genetic disorder. The issue that some people get into, especially when using methadone as a maintenance therapy, you can get some clinically significant prolongation of the QT, but that's with that daily dose stacking and trying to treat addiction. So that's a separate problem. As far as our use, just doing it once. Now, I don't think we should have a methadone PCA. You might run into those problems.
We can hit it every 2 days.
Yeah, 2 days. Yeah, I mean that would probably be fine, but otherwise, yeah, I don't think we should start a methadone PCA thing going. But otherwise, as a first intraoperative dose, I think the data is pretty compelling that it's effective.
It's pretty convincing, but there are still questions as to how much more effective it is than other options. Like, is it more effective than ketamine? Like, is it the activity at the NMDA? Is it the prolonged opioid activity? And then if we were covering the whole surgery with Dilaudid versus just at the end, like how much of a difference would it be? Is it just that we're not adequately treating their pain in the early part of the surgery and they're getting sensitized?
It's possible.
I think some of those questions are good ones to address, but that wouldn't make me not want to use it now.
Right, because just this regimen seems to be working. And I think that gets at the mechanism. Now you're starting to ask how. Because we've got a pretty good data to support what works, this does. Then some of that is, well, why don't other approaches work, or how is this doing its job? And from some of the more basic papers I've looked at, it's actually the NMDA part of methadone is not the main way that it's helping. That's actually a pretty minor component. It's true, but it may not be as clinically significant as people make it out to be. There's other special attributes to methadone that are unique among the opioids that have nothing to do with NMDA. So using those in combination, actually, I think is also pretty effective. But they didn't look at that, right? They didn't do the multimodal or some of these other sort of soup anesthetics that we employ for people. So
I think there's a lot of utility and benefit to learning how to use it because it has some very unique pharmacokinetics too. So getting comfortable with like how you dose it, and if you need to rescue, what can you use, what'll work, it can use more methadone, and getting familiar with it in like situations like this where I think it shows pretty well that there's benefit immediately after, and then even, longer term can be helpful, especially for difficult patients down the line, like who may have substance abuse issues or opioid tolerance. So
definitely.
I think it's definitely would make me want to use it more.
Mm-hmm. And I would argue using it actually isn't complicated at all. You just dose it 0.2 or 0.3 up front, and then you switch to your normal rescue medications guided by respiratory rate and patient level of consciousness. So there's not really a complicated learning component. I wouldn't really repeat the dosing. The onset's quick, it's 8 minutes. So it's faster than even hydromorphone, sort of a peak effect. But beyond that, you would just use all your normal clinical indices of how much opioid is actually affecting them. But yeah, if you just do that bolus up front and then anticipate it'll last, 8 to 12 hours, maybe longer, it's really straightforward.
Well, I think it's a good point though about thinking about systems issues, because one of the things I really feel like for the recovering spine or even cardiac patients, if they're on any PO opioids and a PCA, nurses get really nervous. And so, I think that would be challenging for them to sort of, knowing that you can just titrate as you normally would, but that it has that 6 to 8 hour analgesic effect and then a 40-hour tail. That would, there'd be a lot of questions, I think, that would
If you believe these papers, it has a 6-month tail.
Sure.
But where this has been implemented, there have been no issues. In fact, there's people who've done this for outpatients and sent them home with, opioids to take if they need them. They had no issues.
Yeah, but I think it's definitely makes the case that it's a useful tool in our arsenal to prevent sort of these that acute on chronic pain or just that improved perioperative pain control.
Implementation's going to take a while. Should do an implementation paper sometime. That's real interesting.
Yeah. There's a pretty nationally recognized dissemination implementation group here on campus that does a lot of that work, and they're very helpful with consults like designing a study and that sort of thing.
This stuff is known. Why are we doing it?
Yeah, that's
the question.
Some of it is you go talk to people. So that's the qualitative part that I was talking about. Not for pain necessarily, but you go and you talk to all the nurses. What do you know about methadone? What are your concerns? And then you talk to them until you get, it's called thematic saturation. So you interview them sort of one-on-one, you ask questions, and then once you stop getting new themes, that's how you know you're done. Whether they're like, oh, it's scary, it means they're a drug addict, whatever. So those are themes. And then once you start, new information is not coming in with interviewing more nurses, then you stop. Or whoever else, providers, how do I order post-op pain management? Maybe it's PAs or, the surgeons, whatever else. So that is one way to sort of get at that more rigorously. But just to summarize with the clinical trials, you want to look at who got into the trial, what's their hypothesis, how did they randomize, those are sort of the key components to decide whether you will believe the trial or whether you think they make a good argument. The size of the difference, whether the randomization works, those clues are in table 1. We saw the age was different for some of these, but for the most part, they had good randomization. So if you have a couple of quality metrics, you can look through a clinical trial. And then the other piece that wasn't in this study, there's always a primary outcome, and that's what they designed the study to do. We talked about all the secondary objectives today. They had planned those ahead of time. They're still valid, but they did not pick the number of patients to answer those questions. So if they answered it, they got lucky. That's bonus. The studies are really designed to look at that morphine equivalence first 3 days or whatever their primary objective was. So look at that first, and then secondary is more exploratory. Should we look at these? Then the follow-up would be, okay, let's design a study just to look at a secondary objective as a primary. It can get upgraded. You need another study to do it.
And I learned that probably doing this in cardiac would be a waste of time.
It helps.
It'd be a big act.
Yeah. It'd be a thing of that, yeah,
Yeah,
for sure.
basically, you would need a very large number of patients.
Yeah, and that's effect size too. If it's small, you need more
But
patients.
that gets to what you said, and they were very upfront about there not being a power analysis for this.
No, yeah, there
And
shouldn't
they
be. It's
talk
not
about it in
appropriate.
the discussion as a major weakness, that they didn't, find things because it may have been underpowered.
And remember, power analysis is just a best guess. The power analysis is how you convince funders or review boards or whatever else to let you do the study. You say, we're 80% sure this is going to go great. And they're like, all right, we'll go with that. But seriously, that's really all it is. And then you try and either take other people's data to show that this is what we expect the results to be. But until you do the trial, the data is what it is. So, any questions, thoughts about that? Or
Mine is more practical. How do you get it? Or do you have to go to the pharmacy? Do you have to place an order for it?
yeah, you just call them. It's gotten easier. So I've been trying to give people methadone here for 3 or 4 years. And when I started, there were 3 people who didn't think I was crazy. And then everyone else was like, what, why? What? And then, so over the past couple of years, I feel like more people are using it, and I don't have to go through my spiel and argue with the pharmacists anymore. I think they're used to it at this point. Or
The dose for that patient.
yeah, so you just ask for 0.2 or 0.3. And then you don't want to go. I'm trying to think. Do you stop at 20 milligrams? I usually stop at 20.
That's what Clark says.
Yeah, so you want to, there's sort of diminishing returns, and you don't want to dose it. So if someone's 150 kilos and you ask for your 0.2 or 0.3, that tops out at 20. So
The AIP, it's very easy, it's freely available. I got to be the first one in AOP to order it. And I ordered it because it was an inpatient. As you know, they're starting to do a lot of inpatients in AOP. So I haven't sent anybody home after it yet, but there's no reason you couldn't, but this was an inpatient. So it freaked them out. I said, methadone, we're going to get, but they got it. We were able to get it. So.
yep. If anyone's looking for a QI implementation project.
I think that 20 milligram methadone dose, I've used more than that on occasion. Typically, when I've used it in a higher dose, it's because it's a huge spine case where your EVL is going to be a couple of liters. You're going to lose some of that plasma concentration, as well as people that have high use of opiates at baseline. So those are some patients that I've used it at higher doses.
That'd be the opioid naive recipe. Stop at 20.
So if I've had a patient once upon a time who was on 200 milligrams of methadone a day orally.
Mm-hmm.
What kind of dose do you think you'd give them?
So the conversions aren't that great.
Mm-hmm.
They're all best guesses with that. So I would say you probably stick to the same rules and then just follow your clinical opioid effect the same way. I think that's going to be your safest approach across the board. The published conversion factors vary based on the patient, time of day, dosing, different types. They're theoretical, and you really need a clinical readout to make sense of that. And so titration is going to be the answer on that, especially in the absence of a really solid objective measurement beside respiratory rate. Because you don't have the hot plate foot removal thing. You can't do that to your patients. Even von Frey filaments, right? Pupil diameter, ish. Respiratory rate is the most clinically relevant that you can actually measure.
Tom, what's your thought on whether methadone would be used in the PACU ever as PRN?
PRN.
Do you think it will be?
No, I think it.
Because the same group, I believe, at one point proposed 2 to 4 milligrams IV PRN for rescue doses in recovery, I believe. I read that somewhere.
Really?
Mm-hmm.
that's a pretty innocuous dose, and it's gonna give you the bolus effect, but it's gonna, after we distribute, that affects.
Yeah. I don't know. I wouldn't go after that personally, as at least on a population level. I think as a rescue of someone who hadn't received methadone at all and on class switching, that makes sense. But as far as they got methadone, then we're going to try more of it. I think you go up front with your loading dose, and then that's it. Then you switch to sort of other. I think at least on a practical implementation part of that to do it safely, it would probably be fine otherwise, but. The concern is that they don't stop, right? 2 to 4, 2 to 4, 2 to 4. They don't switch appropriately.
Yeah, I suppose we're gonna max dose. Yeah.
Yeah. All right. Well, thanks very much.
Thanks, man.